Good morning, good afternoon, and welcome to the first NCCN Global Policy webinar this year focused on global cancer care in older adults, improving access to high-quality cancer care for an aging world. My name is Katy Winckworth-Prejsnar, and I'm the Senior Manager of Global Policy and Global Strategic Alliances here at the National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading academic cancer centers, and we are dedicated to improving and facilitating quality, effective, equitable, and accessible cancer care. Through the leadership and expertise of clinical professionals at NCCN member institutions, NCCN develops resources that present valuable information to numerous stakeholders in the healthcare delivery system. Among these resources are the NCCN Clinical Practice Guidelines in Oncology. The NCCN guidelines are utilized throughout the world. We have nearly 1 million registered users outside the US, and last year, over 7 million guidelines were accessed outside the United States. As you can see from this heat map on the right, NCCN guidelines are utilized in nearly every country around the world. The NCCN library includes 88 NCCN guidelines that feature over 220 algorithms. This library applies to 97% of cancer cases in the United States and globally. While the majority of the library includes cancer-specific guidelines, there are 12 supportive care guidelines, 7 guidelines focused on detection, prevention, and risk reduction, and 3 guidelines for specific populations. One of the guidelines tailored for specific populations is the NCCN guidelines for older adult oncology. So why is there a need for guidelines focused on this population? Well, when we look at the statistics, cancer is the leading cause of death among individuals aged 60 to 79 years. With global life expectancies on the rise, cancer in older adults is becoming increasingly prevalent. In fact, it is estimated that by 2030, approximately 70% of all cancers will be diagnosed in adults aged 65 years and older. Older adults with cancer also face unique challenges. They are underrepresented in clinical trials, resulting in less evidence-based information to inform treatment. Addressing older patients with cancer also involves navigating and balancing the benefits of treatment with the risks of reduced life expectancy and diminished stress tolerance. These age-related complexities underscore the importance of developing guidelines that specifically address the distinct considerations in older adults with cancer. You can see on the right the specific topics that this guideline outlines. Some of these topics include screening and comprehensive geriatric assessment, assessing the risks and benefits of treatment, preventing or decreasing complications from therapy, and managing patients deemed to be at high risk for toxicity from standard treatment. When we look at utilization data, in 2023, the NCCN guidelines for older adult oncology were downloaded over 31,000 times, with 63% of those downloads accessed outside the US. And this really underscores the importance of this resource and this topic. As part of a trend survey for an NCCN Global Corporate Council member last year, NCCN surveyed international users of NCCN.org to gather practice-level experience data on caring for older adults with cancer. The survey included 200 respondents from 83 different countries. I'll briefly highlight some key findings, and I think this will help inform the discussions in today's webinar. First, the survey examined the age-specific composition of patient populations, and approximately half of the respondents reported caring for patients aged 60 to 69, and another half reported caring for those aged 70 to 79. Next, the survey inquired about the barriers to making optimal care decisions when treating older adults with cancer. The top 2 responses were frailty and performance status of patients and patient and caregiver concerns. These findings highlight unique factors that influence decision-making for this population. Following that, we explored the gaps identified in practice or country-specific contexts when treating older adults. Across respondents, several areas were noted with percentages typically falling between 30 to 40%. However, the top two gaps identified were inadequate training in geriatric oncology and inadequate screening and diagnosis. These findings highlight critical areas where improvements are needed to enhance care for older adults with cancer. Finally, respondents were asked, when treating older adults, which of the following barriers do your patients experience? The most cited barriers were inadequate social support and financial barriers. These insights really underscore the significance of today's webinar, focused on enhancing access to cancer care in an aging world. In addition to discussing care models tailored for older adults with cancer, this webinar will explore policies and strategies essential for healthcare systems to meet the distinct challenges faced by this population. We are so privileged to present an esteemed lineup of speakers and panelists. The program will begin with a presentation from a clinical leader in this space, Dr. Kanesvaran from the National Cancer Center, Singapore, and past president of the International Society of Geriatric Oncology. He will discuss how healthcare systems can prepare for widespread population aging. Next, we will hear from another leader in the field, this time focused on research. Dr. Pelleran from the Luxembourg Institute of Health will outline ways that big data and post-approval information can help better manage drug reactions for older population. We will then be joined by a group of multidisciplinary panelists who will discuss these issues in more detail and gather their insights and experiences on improving global access to cancer care for older adults. Our moderator for today's webinar is Dr. Weijing Ko. Dr. Ko is Chief Medical Officer here at NCCN, and he oversees the NCCN clinical practice guidelines in oncology and is actively involved in NCCN global initiatives. So at this time, allow me to just briefly introduce our keynote speakers. Dr. Ravi Kanesvaran is Chair and Senior Consultant in the Division of Medical Oncology at the National Cancer Center, Singapore. He's also an Associate Professor at the Duke-NUS Medical School and Clinical Senior Lecturer at the Yong Lu Lin School of Medicine, National University of Singapore. He chairs the National Cancer Center Singapore Office of Population Health and co-chairs the SingHealth Cancer Service Line Development Committee. At the national level, he is co-chair of the Ministry of Health's Drug Advisory Committee and serves as Vice Chairman of the Singapore Cancer Society. He is past council member of the European Society of Medical Oncology and past president of both the International Society of Geriatric Oncology and the Singapore Society of Oncology. We will then hear from Dr. Sophie Pelleran. Dr. Pelleran is an epidemiologist specializing in both aging and cancer and leads the Aging, Cancer, and Disparities Research Unit at the Luxembourg Institute of Health. Her research includes the description of the global cancer burden in older adults and unpacking the drivers of age disparities in cancer outcomes in high and low and middle income countries. We are thrilled that both speakers are here today to share their expertise and experience with you all. Their presentations have been pre-recorded, but we welcome the opportunity to answer your questions during the panel discussion, and feel free to put those questions in the Q&A chat. Last but certainly not least, NCCN truly appreciates and recognizes the supporters and sponsors for this webinar. Without your support, this webinar would not be possible, so thank you. We look forward to an active conversation today. Welcome your questions and engagement throughout the program. And with that, we'll go to the keynote presentations.
Hi, my name is Ravi Kanesvaran. I'm a medical oncologist at the National Cancer Center, Singapore. And today I'm honored to be given this opportunity to share with you my opinion on how health systems can prepare for widespread population aging, specifically in relation to our cancer patient population. The outline of my talk today would include some description of global aging demographics, aging and its relationship with cancer incidence, and how we can prepare our healthcare systems for an aging population with cancer. And then I'll quickly summarize. As we all know, this is data that's quite well known. Our life expectancy has improved tremendously, especially from the 1930s with the innovations like antibiotics, better healthcare. We are seeing lifespans increase across the globe. As you can see here in 2021, the average lifespan of a human being is 70 years and above. Of course, there's some disparity between continents, but nevertheless, it is an upward trend. And all these can be accounted for by better healthcare. However, the percentage of the global population aged 65 years and above is increasing as well, meaning the world is aging at a rapid rate. You can see here from 2022, roughly about 10% of the population is aged 65 and above. And by the time we reach 2050, on average, globally, it'll be 16.4%. There are certain parts of the world, like Eastern and Southeast Asia, where a quarter of people will be aged 65 years and above. And similarly, in developed parts like Europe and North America, they will be going through this aging tsunami as well. Now, in countries like Singapore, we'll actually hit this milestone in less than 5 years. So there are many countries or pockets of areas where we're going to see rapid aging. And this has a lot of implication on healthcare systems. Now, I'm just going to zero in on cancer and its relationship with aging. So with increasing age, there's also increasing incidence of cancer. So on your left-hand side, you can see the dark blue bar representing patients with cancer who are more than 70 plus years. And you can see as time goes on from 2022 right up to 2050, the proportion of patients who are older with cancer is increasing. Similarly, older patients are more susceptible to death from cancer as well. And on the right-hand side, you can see this representation from 2022 to 2050, showing that older patients, those 70 and above, are more likely to die from cancer. And this proportion is only going to increase with time. As such, there have been a number of initiatives globally trying to understand this issue in greater detail or granularity and come up with solutions to address them. One of these reports was the When Cancer Grows Old report, which was done by KPMG, a consultancy firm, and was supported by leading cancer organizations like UICC and the International Society of Geriatric Oncology. On the left-hand side, as I mentioned earlier, cancer incidence in terms of the rate per 100,000 persons is more in the older population. When patients of, the population of patients who are 65 years and above are more likely to have cancer compared to their younger counterparts. And this report specifically looked at the socioeconomic burden of cancer and aging, and what are the policies that we need to put in place to address them. Now, I'm going to highlight some key data from this publication. Firstly, in terms of economic cost. As you can see, this cross-section looking at multiple tumor types across the 7 countries, which were China, the US, and the 5 largest EU countries, UK included as well, France, Germany, Italy, and Spain. They all are seeing quite a significant impact in terms of economic costs, in terms of disability, adjusted life years as a percentage of their gross domestic product. Now, if you put these regions side by side, on the right side, you can see there clearly over time, this proportion in terms of the cost to the economy of patients with cancer who are not able to contribute to the economy anymore because of their illness. And this takes into account, caregivers as well, who now have to give up their jobs to take care of these cancer patients. All in, about 2 to 3% of the GDP would be lost in terms of economic cost to it. So how do healthcare systems prepare for an aging population with cancer? There are a number of strategies that I'll outline here, and we'll go into slightly greater depth in the next few slides. Firstly, we should actually come up with strategies to detect these cancers early and screen them, right? Of course, if you take one step before that, there should be also a prevention program, and we'll talk about it in a short while. Once an older adult has cancer, we should then try to strategize appropriately, assess them appropriately, and individualize cancer treatment to that older adult. And this would include improving expertise in geriatric oncology, the field that deals with this. Last but not least, we need to equip healthcare systems with the appropriate resources. And if resources are limited or restricted, we should then try to optimize whatever resources available to address this impending challenge. Now, I'll give an example of how we are doing it here at the National Cancer Centre, Singapore. Now, looking at the continuum of cancer care from prevention right up to palliation in late stages, these are some of the things we are developing, including a national cancer screening and prevention program in our strategy, then establishing uniform protocols and pathways for consistent multidisciplinary quality care. This includes standardizing diagnostic reporting, as listed here, and integrating phenotype and genotype databases for individualized treatment, and not forgetting, getting patients, involved in cancer rehabilitation and survivorship programs. And last but not least, we want to coordinate timely, accessible, affordable, supportive, and palliative care, and make sure these patients are right-sited appropriately. So I'll go into a great bit more depth in the next few slides with regards to some of these strategies. So let's talk about early detection and screening. Now, the focus would be on preventive measures for a start, which includes, coming up with cancer education programs, public education, cancer awareness, working with civil society, community societies where we engage the general public on measures, lifestyle changes, and how to prevent cancer. Next, we would expand cancer screening programs. Unfortunately, in many Asian countries, in spite of screening programs not costing very much for the general population, there's still a bit of a taboo and a resistance from the population. For example, in Singapore, a lot of these programs only see rates of about 30 to 35%, with many patients not getting screened, despite the fact that these programs are literally cost-free for these patients, for this proportion of population. We also need to develop age-appropriate screening strategies. And last but not least, with evolving technology, we need to look into better detection methods, better screening programs. This includes looking into multi-cancer early detection technology or platforms that are now slowly coming into place. And we need more in-depth research to actually justify the use of these technologies in the general population, and to alleviate fears that there could be a lot of, false positives that's going to increase anxiety. So in the Cancer Centre, as mentioned, we have a Screen for Life program, which is a national program in Singapore that screens patients for breast, cervical, and colorectal cancer at an appropriate age. And there's also a cancer genetics program. Let's not forget about patients who have germline mutations, who are at high risk of hereditary cancers. They need to be screened regularly, and their families need to be screened as well, as cascade testing is critical in seeing who are going to be the affected population. Now, what about geriatric oncology assessment and treatment? First of all, it's not available everywhere. I think slowly organizations like the International Society of Geriatric Oncology is going about trying to disseminate this information, train the workforce, but we need to invest in this expertise. We also need to develop supportive care programs and increase access to palliative care. While in many developed countries, this is a given, unfortunately, in many low middle income countries, there's no access or limited access to palliative care, which unfortunately makes the end-of-life care quality extremely poor. So we should try to invest in these training programs. So in order to do that, SIOC has come up with 12 priorities. This was published in the Lancet Oncology about 2 years ago. It's an update from another policy document published a decade before that, which was the SIOC 10 priorities. In these 12 priorities, we outlined 4 key areas: education, clinical practice, research, collaboration, and partnership. Now, I'm not going to go through in detail. You can get this from the publication itself, but just, to outline the fact that education involves, right from the medical school or training programs, right up to, trained healthcare specialists, and giving them appropriate tools, knowledge that they can use on their older patients. We also want to educate the general public as well. Now, in terms of clinical practice, we want to standardize guidelines. We want to develop guidelines for optimizing care in older adults with cancer. Now, research is ongoing in many centers. We want to, of course, extend this across the world because every population is different, and we need to understand the older adult population in that particular region a bit better. Last but not least, SIOC is trying to collaborate with multiple organizations, community-based organizations, policymakers, advocacy groups, to try to, highlight the importance of geriatric oncology in their respective healthcare systems. Now, in that process, SIOC has a geriatric oncology advanced course conducted yearly at the Catholic University in Treviso. Here, various healthcare providers, including nurses, geriatricians, oncologists, can get early exposure and fundamentals in geriatric oncology. This will help establish multidisciplinary teams, and we hope that the participants will go back to their home countries and use these models to care for the older adults with cancer. We're also looking at novel models of providing geriatric oncology care. And as such, now we have geriatric oncology sprouted right across the globe, quite well developed in countries like US and Canada, and North America, in Europe. However, there are many new centers, popping out in Latin America, Asia, and of course, there are centers in Oceania, specifically in Australia. So slowly but surely, there is information dissemination, training in geriatric oncology that's going to help a lot of, older adults with cancer. Last but not least, I want to focus on healthcare system resource management. I mean, we are all aware that, healthcare resource is finite, and it depends a lot on the country's ability to support such care. But knowing that we're going to have this impending challenge of a large proportion of older cancer patients with a lot of comorbidities, a lot of other issues that need to be cared for, we need to strategize the optimal way to use these resources. We need to promote shared decision-making amongst patients so they are able to choose what they want for themselves, especially when they're older, when they may lack capacity to make decisions and may need more support. We need to support research and innovation. This requires investment, but with collaboration, we can actually achieve some of these things without so much of an investment when we all do it together. Hence, we need to promote collaboration. So I'd like to summarize by saying, firstly, global population is aging rapidly. Cancer incidence is rising in tandem with aging populations. The economic cost of cancer is becoming a significant financial burden for many countries across the globe. We need to address that. And healthcare systems globally need to make policy changes to address these challenges of cancer and aging before it overwhelms their healthcare system. So advanced planning, of course, is going to help us solve these issues further down the line and make that transition a lot easier than having to do it when it hits us, because it will hit us. It's just a matter of time. With that, I would like to thank you and also mention that the International Society of Geriatric Oncology will be having their annual meeting. So it's a wonderful place to meet like-minded people who care for older adults with cancer. And I would like to thank you for your time and your attention.
Hello, everyone. First, I would like to thank NCCN for inviting me to participate in this webinar. My name is Sophie Piron. I am an epidemiologist specializing in aging and cancer. I am the group leader of the Aging, Cancer and Disparities Research Unit at the Luxembourg Institute of Health. I'm also a board member of the Nursing Allied Health Interest Group of the International Society for Geriatric Oncology. Today, I will talk to you about the use of real-world data in improving cancer care in older adults. Okay, first, I will describe to you the drug development process until it reaches the market using the FDA, Food and Drug Administration, as an example. The development process is a rigorous and multifaceted procedure designed to ensure that drugs marketed are safe and effective for the intended use. First, researchers identify potential drug candidates and conduct thorough laboratory research called preclinical studies to understand their mechanism of action and evaluate their safety. Next, if preclinical studies show promising results, the drug sponsor, which is usually a pharmaceutical company, but could be an individual, submits an application to the FDA, which describes the preclinical data and the proposed clinical trials. Drugs are then tested in humans in clinical trials. There are basically three phases. First, phase 1 studies are small studies involving healthy volunteers to assess safety, dosage, and initial efficacy. Phase 2 studies are larger trials involving patients with a targeted disease to further assess safety and efficacy. Phase 3 studies are large-scale randomized control trials to confirm efficacy, identify side effects, and gather additional safety data. After completing phase 3 trials, the drug sponsor submits a new drug application to the FDA, compiling all trial data to request approval to market the drug. The FDA reviews the application, evaluating the drug safety, efficacy, manufacturing processes, labeling, and benefit-risk profile. If the FDA determines that the benefit outweighs the risks, the drug is approved for marketing. The FDA may also request additional information or clarification before granting market approval. Once marketing, the FDA, like other regulatory agencies, continue to monitor the drug safety and efficacy. After a drug is marketed, it's essential to continue monitoring it to identify any adverse effect that may not have been detected during clinical trials. These trials, usually short-term and conducted on a limited and highly selected populations, may not reveal some adverse effects that can manifest in specific patient subgroups who are not included in clinical trials or after long-term exposure to the drug. Studies show that 1/3 of newly identified safety issues post-marketing are added to the warnings and precaution section of the label, highlighting the seriousness of this adverse effect. When an adverse effect is observed following drug intake, doctors must report it using a standardized report. When a sufficient number of adverse event reports are associated with the same drug regulatory agencies investigate the signal. Case reports published in scientific journals are another important source of information in pharmacovigilance. Each time a signal is investigated, regulatory agencies conduct a thorough literature review. However, signals and case reports as data sources are limited by their incomplete, biased, and inconsistent nature. This is why, with the emergence of new technologies and the digitalization of health data, real-world data are becoming increasingly important in monitoring drugs post-marketing. Real-world data include electronic health records from hospitals, medical laboratories, GPs, or drug and care reimbursement data or insurance claims. Basically, real-world medical data are all data collected each time you encounter a healthcare professional. Information shared on social media or forums can also be used, although it's unstructured and often fragmented. Another explored source is the use of digital tools. The advantages of real-world data are numerous. These data sources contain a wealth of information and capture the diversity of the population of interest, in our case, cancer population. Real-world data are quickly available, allowing for faster results, thus accelerating the research process. And due to their availability compared to traditional clinical studies, the use of large-scale data is often cheaper. This data offer as well the possibility to study long-term treatment effects and adverse events, as well as discontinuation and additional treatment, thus providing complementary information relevant to the population. They can also be the only viable option to obtain answers to certain complex research questions or to questions related to rare diseases or in cases where clinical trials would not be ethical. There are also several challenges. Access to data can be complicated due to legal restriction, institutional policies, or privacy concern. Data protection is a major concern, especially in healthcare, where sensitive information may be disclosed. Robust security measures must be implemented to prevent any breaches of data confidentialities. Data from different sources or institutions may be stored in different formats, making their integration and analysis difficult. Interoperability of system and data formats is essential to facilitate exchange and collaboration between institutions. Real-world data are observational data and inherently subject to various biases that can compromise the validity of results. Biases such as selection or confounding can affect analysis and require special attention when planning the study and interpreting results. Regulatory agencies around the world are working on designing framework to use real-world data and evidence when they are in the post-marketing monitoring. Now let's discuss how real-world health data can be used to improve cancer care for older adults. For a bit of context, according to the latest estimates, about 20 million new cancer cases were diagnosed worldwide in 2022, half of which concern people aged 65 and older. And this number is expected to increase in the coming decades, especially in low and middle income regions. So older adults constitute the majority of patients seen by oncologists every day, and their number will continue to grow in the coming years. However, older adults are often excluded from cancer research, particularly randomized clinical trials, which, as we have seen, are the standard method for studying treatment efficacy, including cancer treatment. This chart illustrates the percentage of people diagnosed with lung cancer in the United States who participated in clinical trials compared to the proportion of people diagnosed with lung cancer in the general population, categorized by age group. And from that chart, we can easily see there is an overrepresentation of patients aged 40 to 64 in clinical trials, while there is an underrepresentation of those aged 75 and older. The reasons for this underrepresentation are multiple. One reason for their exclusion is that older patients often have multiple health issues and take several medications, making it harder to meet clinical trial eligibility criteria. Another reason is that older patients are less likely to be referred to clinical trials by their doctors. This can be due to a lack of knowledge about available trials or concerns about the potential risks and benefits of participation. Finally, there may also be logistical barriers that make it harder for older patients to participate in clinical trials. For example, they may have mobility issues that make it difficult to travel to study sites or participate in certain activities. Why do we need specific information for older adults when oncologically speaking, their tumor are the same as those in younger individuals? With aging, physiological system change and become less efficient, and older people are thus more at risk of toxicity and complication. And currently, because of the underrepresentation of older adults in clinical trials, doctors must take treatment decisions without information about toxicity and complication. A quote perfectly summarizes the problem. It's a quote from Dr. Supriya Moile, a geriatric oncologist from the University of Rochester, who dedicated time to improving cancer care for older adults. In one of her interviews, she said, "We arm and then we adapt," in reference to new drugs coming to market. And the low representation of older adults in research results in a risk of overtreatment, meaning the treatment given is too heavy or poorly tolerated by the patient, but also of undertreatment, meaning the person could have tolerated heavier treatment than those prescribed, which can impact their risk of toxicity and complication, and therefore their quality of life. So in this context, real-world data represent an opportunity to improve knowledge on assessing the risk of toxicity and complication of certain drugs in this population, but also to test the efficacy of certain treatment strategies, such as reducing chemotherapy doses in breast cancer compared to the standard regimen. Here is one example related to cancer that use real-world data to provide complementary evidence on the effectiveness of a drug in a specific group of patients, node-positive prostate cancer patients, who are underrepresented in clinical trials and therefore for which we have little evidence. And this study compared overall survival in men with node-positive prostate cancer who received adjuvant radiotherapy to those who were under observation using the National Cancer Database in the US. This other work, published work, used also real-world data to study the optimal timing of allogeneic transplantation in hematologic tumors. Treatment timing is usually not evaluated in clinical trials. Another example where real-world data could be used is to assess the effectiveness of recent therapies such as immunotherapy, particularly immune checkpoint inhibitors, which has revolutionized cancer treatment by offering more manageable options with durable results. Evidence from randomized clinical trials indicates comparable clinical efficacy of immunotherapy in robust older adults compared to their younger counterparts, but little information is available for more frail adults. Real-world data can be then used to explore the effect of immunotherapy on frail older adults in real-world setting to ensure they receive safe and optimized care. In recent years, healthcare has evolved toward patient-centered medicine, aiming to improve health outcomes by considering individuals' preferences, goals, values, and available resources. So beyond conventional outcomes such as survival or functional toxicity, patient-reported or measured outcomes such as quality of life or functional status now play a vital role in clinical decision-making. And real-world health data can also answer this type of question. However, older adults are a heterogeneous group of persons ranging from very poor to very good health. Treatment management can also be complicated by cognitive impairments, hearing and vision difficulties that can complicate communication and understanding of medical information. The social network often shrinks with age. It can be challenging to find someone to take the older person to medical appointment, especially if they are limited in their daily activities. Beyond the medical aspect, the social aspect of the older person must also be considered when deciding the treatment strategy. And all these medical and social elements are considered during therapeutic decision-making, and all these factors influence cancer outcome. So to reflect the heterogeneity of this population, we need information different from that of younger adults, including information on social dimensions. However, these data are not systematically available in electronic health record and therefore cannot be used in analysis, although they play an important role in the decision-making process. Moreover, due to the underrepresentation of older adults in cancer research, current medical practice and thus the available real-world medical data may not reflect optimal cancer treatment or management in older adults, and analysis using this data could perpetuate suboptimal treatment due to the absence of other information. And finally, for various reasons, older adults are more likely to refuse treatment than younger adults, and those who refuse treatment have worse outcomes than those who do not. However, information about patient treatment refusals is not recorded in electronic health data, so this information cannot be used in analysis as well. Therefore, we cannot know from the data only what would have been the cancer outcomes if the patient had agreed to the treatment plan. Fortunately, the situation is changing. Regulatory agencies such as FDA in the United States or the Europe Medicine Agency in Europe recommend the inclusion of older adults in clinical trials. Additionally, recently, several clinical trials on the effectiveness of geriatric assessment in older adults with cancer have been published, and ongoing clinical trials recruit adults aged 70 and older. The Cancer and Aging Research Group and the International Society of Geriatric Oncology advocate for better inclusion of older adults in clinical trials. And ASCO very recently reiterated their recommendation to use comprehensive geriatric assessment together with targeted interventions to improve tolerance to treatment. Combined with new therapy better tolerated by older adults, this opportunity helps change medical practices to the benefit of older adults. When a holistic approach to managing cancer in older adults becomes routine practice, real-world data will be even more useful. In conclusion, real-world data is an incredible opportunity to improve cancer care in the older population, which again represents the vast majority of patients seen routinely. To harness the full potential offered by real-world data, it's essential to work towards including older adults in clinical trials, but also to include geriatric variables in all clinical and observational studies to be able to assess patient fitness from the data. Thank you very much for your attention.
Well, thank you so much to Dr. Kanesvaran and Dr. Pillaran for their great keynote presentations. We're now going to transition to a panel discussion that includes our two keynote speakers as well as three other experts that can share their unique perspectives. So my name is Ravindran Ko, and I have the privilege of serving as the Chief Medical Officer here at the NCCN. I would like to turn this over to our panelists. You've already heard from two of them, but in turn, I would like to invite Dr. Kanesvaran, Pillaran, Ms. Lavery, Mr. O'Shea, and Dr. Roscoe to spend a couple of minutes, minute or two each, to describe their background, if they haven't already shared this, and share why they believe they are included in this panel discussing cancer care in an aging world. So start with Dr. Kanesvaran.
Thank you so much, Dr. Ko, for this kind invitation. I'm Ravi Kanesvaran. I'm a medical oncologist, and I chair the Division of Medical Oncology at the National Cancer Center, Singapore. I have an interest in geriatric oncology, spanning more than 15 years now, and I've been closely involved with SIOG, or otherwise known as the International Society of Geriatric Oncology. Thank you.
Thank you. Dr. Pillaran?
Thank you very much. Hello, everyone. First of all, I would like to thank NCCN for inviting me to participate to that event. I'm Sophie Pilleron, epidemiologist specializing in aging and cancer. I lead the Aging, Cancer and Disparities Research Unit at the Luxembourg Institute of Health. And I have an expertise, as already said in the presentation, in analyzing real-world data, also known as observational data in the field of geriatric oncology, a field in which I've been active for several years now. And my work is essentially known for the description of epidemiology at global and regional level using cancer registry data. Thank you very much.
Thank you so much. And turning to you now, Ms. Lavery.
Hi, thank you. My name is Bea Lavery. I'm Vice President of Regulatory Affairs at Genentech Roche. And for the last 20 years or so, majority of that being in oncology drug development, I've had the opportunity to interact with regulators globally and through those conversations, see a real strong need for us to think differently about the inclusion of patients who typically aren't included in clinical research. And in recent years, partnership with SciOg and learning more about what we can do differently for patients that are older. That's why I'm here today. So thank you for the opportunity.
Thank you. Moving on to Chuck O'Shea, a patient advocate.
Good morning or afternoon. I'm co-chair of Stakeholders for Care in Oncology and Research for Elders Board, which we call Scoreboard. I've been a cancer patient now since 2008. I was diagnosed with non-Hodgkin's lymphoma, and I'm proud to say that I've been in remission for about 13 years.
Thank you. And finally, but not least, Dr. Roscoe.
Hello, everyone. My name is Ashley Roscoe. I'm a professor in the Division of Hematology at The Ohio State University, and I'm also the medical director of the Oncogeriatric program here at Ohio State. I created and co-direct a cancer and aging resiliency clinic, a clinic that is a multidisciplinary team to be able to integrate geriatric oncology assessments and plans as part of routine oncology care. In addition, I'm an FDA ODAC standing member, and so I hope to be able to integrate how we can implement geriatric oncology needs and also integrate policy around health systems and clinical trials for older adults with cancer.
So to begin, let me pose this first set of questions to Chuck. You know, at the end of the day, what we're trying to do is improve and accommodate and advance patient care. So I think the patient voice is the most important. So Chuck, as a patient advocate, as a previous cancer patient, and thankfully as a cancer survivor, what were the unique challenges that you perceive that you yourself or other patients who are considered older face when they go through cancer treatment or when they are actually faced with a cancer diagnosis and make decisions and proceed through a cancer care course?
Yeah, this is I wish this was an easier question to answer. Part of the problem is there's too many challenges that we face as older patients. One of the biggest things I believe is trying to decide what you want your outcome to be. How important is quality of life? It's right at the top of my list. I want to know that at the end of treatment, I'm going to be at least functional and be able to carry on a somewhat normal life. And I think that's a huge question. Unfortunately, we walked into the situation with two strikes against us. One is we've got cancer. The other is we're old. We've got two comorbidities just to start out with, and then we probably have at least one or two others. I think that again, that's kind of against us. And a third really big one is the cost of cancer care. As an example, when I was being treated, the cost was $25,000 per visit. And if I had not had insurance, I think it would have changed my and my wife's life for the rest of it. I don't know that we could have afforded it. We'd had to make some really tough decisions. Those are just three. I mean, there's transportation, there's drug interactions, polypharmacy. So yeah, there's a bunch of challenges we have to face, and we have to figure out what we want to do.
No, thank you for the perspective. It does seem that we have only lately recognized this issue. I think in the discussions that Dr. Kanesvaran and Pejsnar shared, not only is there an aging population throughout the world, but even before we get to the place where 25% of our populations in many parts of the world exceed 65, we already know that cancer is disproportionately incident in the older Asian population. I believe Dr. Pejsnar showed that 66% of, more than 50% of cancers occur in patients who are 65 years of age or older. I do want to touch base on something that you mentioned, Chuck, in terms of the non-necessarily physiologic barriers to treatment, because in the poll that Katy showed at the beginning, they talk about financial barriers and inadequate social support. So you talked about this beyond, physiologic fitness and frailty. How much do you perceive that to be an ongoing barrier to care among the older adult patient population?
From the financial point of view, I think it's huge. The older you get, there's those of us who have been fortunate and had good jobs, ended up with good pensions, and we're okay. But I think we're not the majority of people out there, and without that, I don't know how you even make decisions about what you choose. The other part of that answer is you really need someone with you to go through this process. I can't imagine having done this by myself. I'm also a volunteer at a hospital, and I watched the pandemic, and I watched what was going on, and the fact that you were not allowed to bring people in with you for your visit. I try to imagine what my visits would have been like without someone with me to listen to what was being said, to help understand what was being said. I know early visits, what I heard was I had cancer. That's what I heard. My wife was the one who heard everything else and was able to be encouraging and let me know that that we were going to get through this. It would be okay.
Great. No, thank you for sharing that and highlighting the importance of someone to support you through the cancer journey. Let me turn to Dr. Roscoe. I have a series of questions for you. How often do you encounter this patient demographic with these challenges in your everyday practice?
So, so extremely commonly. In fact, that was really the genesis of creating, our Cancer and Aging Resiliency Clinic at our institution. I think one of the most challenging things that I find as an oncologist is that it is a complex place to navigate in terms of, the logistics of time, being able to adequately review a complex cancer diagnosis, to be able to go over treatment toxicities, to go over, the plan for the day in a limited patient visit. There are logistics to administering care, and then to be able to also address all the other impacts, how cancer has this major rippling effect, as Chuck has pointed out, not only with in terms of the toxicities of the therapy, but all of the other aspects that it impacts life. And so in doing so, we've created a clinic to be able to identify and implement needs for older adults specifically. really kind of being able to systematically administer a geriatric assessment and be able to identify the needs of older adults from all different levels, from a functional perspective, from a memory, from a nutrition, from a social standpoint, and even to cover things like that are important to what Chuck has identified in terms of the financial impacts, travel, access. All of these things have a rippling effect. But as a treating medical oncologist, there are logistical challenges to be able to identify these needs and to be proactive about them. And I think that's what's most important when we talk about older adults, is to say, let's not wait until, the wheels fall off the wagon, when someone's losing weight, when they've had a fall, or, that there are other aspects of their health that, they realize that, like the financial barriers that we're running into, transportation, et cetera. And so I think what's so important about, talking about this from a global perspective and talking about it from a policy standpoint as well, is to be able to be proactive about the needs for older adults from the time of diagnosis, and then to be able to assess and reassess those needs over a period of time. And so, as the data kind of has pointed out, we typically were seeing patients, in their 60s with a new diagnosis, but now we're seeing many more patients that are in their 70s, in their 80s, that are thriving and are doing well, and with a new diagnosis of cancer. And so there are lots of other needs when it comes to seeing an older adult that comes into the clinical practice. And so I think particularly when we're seeing, one of the challenges that we face as a treating oncologist is that when we see patients that are octogenarians in their 80s, a lot of our treatments are not, designed from a clinical trial standpoint for older adults, specifically in those ways. And so being able to use the skill set of to borrow from the field of gerontology and to be able to implement that into our practice, to be able to start with treatment decisions, to be able to say, would this patient benefit more from surgery, or more from radiation, or more from chemotherapy? We have a lot more treatment options now. And so I think it's a really fantastic way that, for us to talk about, all of these really important measures when it's so. To answer your question in brief, Dr. Ko, how often do we run into these? Every single day, and I think every single day when we have a patient coming in, and I think the most important thing about this is how do we be proactive from the start of the diagnosis?
No, that's wonderful to have this proactive approach in. Let me ask you, you're a member of the Older Adult Oncology panel for NCCN. I understand that, the definition of is perhaps a pragmatic definition based on Medicare, but the panel has chosen to use 65 as a definition, but one recognizes that that is somewhat arbitrary, and recognizing the how do you reconcile that with a population that's going to go increasingly older? You mentioned patients in their 70s and 80s. Do you need to then adhere those guidelines to a variable age population, above a certain cutoff age, if you will?
Yeah, so I think, so the NCCN we have made a statement within our guidelines is that there really is no chronologic age to be able to define an older adult. But at the same time, we recognize that based really upon Medicare guidelines, that age 65. And so we've kind of put in terms of the standing measures, it's, recommended for all adults 65 years and older to undergo a geriatric assessment. And this is really recognizes some of the great data that Dr. Pillaron, had presented here today, and Dr. Kanesvaran about, we know that vulnerabilities and occult vulnerabilities increase as one ages. But there is, of course, no defined age into which that is, and saying, here's where we're really kind of finding these occult, vulnerabilities. But from a health system and a health policy administration standpoint, being able to say, okay, let's really start screening at age 65. And that gives us a better sense in terms of where we're able to best meet the needs for older adults with cancer.
And, I know you have done a lot of research work in evaluating biologic versus chronologic age. Could you, expand a little bit of that briefly? I think you've touched on some of that. How do you evaluate and put that into your perspective and into your practice?
Yeah, I think this is, really one of my most passionate areas when we look about, kind of aging research as a whole, to be able to integrate aging science into part of our routine oncology care. And so when we talk about biologic age versus chronologic age, chronologic age is, what, many of our studies are designed upon about we're going to enroll older adults, and we categorize that based upon an age threshold, typically around 65. But if you look at our older studies, it was even younger than that. But biologic age really is saying, we know clinically, and this is what we've done for years and years, is when we're assessing a patient based upon their chronic age, we'll say things like, this patient appears greater than their stated age. Or, we see patients that are really thriving and, kind of perhaps maybe unexpected for their chronologic age. And so it gives us a sense about what biologic age really is. A biologic age is dependent upon a number of factors. It's dependent upon lifestyle, in terms of choices over a lifetime that someone has made, whether that's, the way that they're eating, or whether they're integrating exercise measures and lifestyle choices that have accumulated over a period of time. It's dependent upon, biologic age is dependent upon comorbidities, not only having, different diseases, but how well controlled those. But also biologic age is dependent upon genetics. We know that there are long-lived families and that there are, differences among families in terms of the genetics. And what is so fascinating is, and what, perhaps the holy grail is, how do you measure biologic age? And how do you really capture someone's true physiologic age and ways to do that? And that's a lot of what our research and a lot of the global research is, and geroscience is to say, how do you really measure someone's physiologic age? And there are lots of ways that we use it, using aspects of a geriatric assessment, using both subjective and objective assessments to be able to characterize the biologic age. And then there are other measures that are, under research, things that looking at sarcopenia or muscle mass. Looking at, blood-based assays to be able to look at the immune systems and portions of the immune system. But I think what the hardest part about biologic age is that it needs to be independent of the disease state. And that is particularly important for a patient with cancer. It's a little bit more complicated because, cancer affects the whole body in all kinds of ways. And to be able to measure biologic age makes it particularly unique. And so I think this aspect of biologic aging is what we're trying to really hone in on when we're looking at aspects of the NCCN older adult oncology guidelines. Is saying, there are so many different aspects of your health, whether that's cognition and nutrition and body mass index and your a lot of our functional measures, our self-report, but also objective measures to be able to really characterize your overall health. And I think what's important to measure is that, often what comes up is, like what is the one thing that matters the most? And we know that that's, not just one thing. We also know, that, social support, social influence, all of those things really influence trajectories of health as well, particularly with a cancer diagnosis. And so I think, what we're really trying to get after here in terms of our NCCN guidelines is saying, all of these aspects impact, this physiologic health for a patient when it comes to a treatment decision, when it comes to the trajectory of cancer over time, and even through survivorship.
Thank you so much. Dr. Kanesvaran, thank you so much for, your very insightful presentation. Couple of questions. Thank you for your leadership in the geriatric oncology sphere. What are some specific policies, and you talked broadly, but are there some specific policies that you've implemented at the National Cancer Center in Singapore that you feel have been particularly successful? And a broader question beyond that is, when you mentioned that each area nation has unique needs, but are there, because we are in a global policy summit, are there things that you say that may be generalizable to hospital systems globally, even though we recognize that each system has unique characteristics and resources?
Thank you, Dr. Koh. They are excellent questions. I think I'll start with the first question, which is about some of the policies implemented at my center. Basically, we are part of a nationwide healthcare system. So we're a public hospital and one of 3 cancer centers in Singapore. And what has happened in the last couple of years, actually now roughly about 2 years, is that there has been a national initiative to look at how to make Singaporeans healthier. In fact, it's simply called Healthier SG or Healthier Singapore. And this policy, as I had shown in one of my slides, covers the whole cancer continuum, from the point, we try to screen and, catch cancers early, even before that, in terms of prevention. So there's a national screening program called Screen for Life, and this is subvented or subsidized or reimbursed by the government, so patients don't have to pay to get the screening tests done at the appropriate age. Moving down that pathway, we've also got initiatives in diagnostics, therapeutic support in terms of reimbursement there as well, using a cancer drug list developed by our Health Technology Assessment Unit, because as you know, cancer cost is expensive, and we need to find ways to try to make these drugs affordable. And prior to this 2 years, there was just not enough support for cancer patients in that aspect. So now we have an HTA, reviewing these drugs, looking at cost effectiveness and putting drugs that are cost effective in that list. And right on to survivors, and of course, not forgetting terminal patients who need palliation. So it's kind of a whole cancer continuum spectrum. And one thing I have to mention is it is very resource intensive. So it's expensive, something that may not be easily applied across the globe. As you rightly mentioned, we have so many countries with many challenges, specifically with resources. So if you were to ask me, and this is to answer the second question, are there bits and pieces of this that perhaps countries that are not well resourced could look at? I think spending some money or resource, whatever limited resource they have in the screening space, may probably give you, the best bang for your buck. And for example, as part of our global health initiative in Singapore, we are trying to, help countries in the region who may have, challenges in this space to improve in those areas. So currently, I'm working on a project with Bangladesh, with specifically Bangladesh University in Dhaka. They have a health economics unit, and we had discussions with them. And because the cost of doing these initiatives there is not that high by, let's say, countries that have more resources and income. With a small sum, we managed to go in and are screening now thousands of patients for breast and colorectal and cervical cancer. So what I'm trying to say is, I think a lot of us can play a big role in helping, low middle income countries by technology transfer, expertise transfer. And that's where SIOG is trying to play a role in. And if you recall, I've shown the 12 priorities. This kind of gives a framework for countries to follow in order to, rise up to the challenge of dealing with older adults with cancers. And it was interesting that you mentioned the age group 65. So I think globally, WHO uses that as, the age group where we define older adults. SIOG traditionally has used the age 70 because, as mentioned, it was formed in France, and with a lot of members coming from developed countries, 70 seemed like a reasonable cutoff. Because any lower, and then we'll be overwhelmed, in terms of the volume of patients that we need to deal with. But if you look at India, for example, the average lifespan of a male in India is roughly about 68 years old. So my colleagues in India, in Mumbai, in Tata Memorial Hospital, where they run an Oncology program, they use an age cutoff of 60 because it makes sense for the Indian population, right? So I think this is just, as you mentioned, an arbitrary number, but a number that you can choose depending on where you are geographically, depending on what average lifespan is of that particular population and what your resources are. Because if you have it too low as well, and then you may find, you have too large a population to deal with. So in many developed countries, actually, it's probably 70 years old. In many Oncology programs in France or North America. Thank you.
Thank you. Now, it's great to put things in context. You did mention, I believe, in your presentation, age-appropriate screening strategies. And I recognize the importance of screening. But as one gets, older in age, do you incorporate in your age-appropriate screening strategies perhaps an appropriate reduction in screening? For example, we do know that above a certain age, and again, arbitrary, that, the diagnosis of malignancy in the breast or prostate cancer may not be as biologically significant as being at a younger age. So how do you reconcile your messaging versus your, use of resources, particularly in, resource-constrained settings?
Well, that's an excellent question, Dr. Koh. And I think, again, you have to put things into context based on what your average lifespans are in that particular country. So as we move forward, and we're going to see, many of our populations age rapidly. For example, in Singapore, in 5 years' time, 1 in 4 older adults will be more than 65. So while I recognize that, many, organizations like USPTF, for example, has an upper limit, after which you wouldn't want to screen because, picking up cancers thereafter with all the other downstream effects of, treatment and so on may not actually benefit such populations. Hence, there's kind of a age range for a lot of these screening tests may apply depending on what the population is like. So if we're going to see many patients living beyond their 80s and 90s, then we need to rethink that concept of having that upper age limit, right? Because they're going to be fitter 80-year-olds, fitter 90-year-olds. And then we need to go back to our regulators and tell them, you know what, this is our data right now. In the past, maybe 80% of our 80-year-olds were frail, right? And getting diagnosed with cancer at that point, where they're not going to be fit to receive any treatment, may not be useful, right? But now, 50% of our population are frail and the other 50% are fit. So should we rethink that upper age limit of 70 or 75 for screening? When you're going to see them have a runway of another 10 or 15 years of healthy life, or what we call health span, right? Now we're going to move away from lifespan to health span, right? We have these blue zones in many pockets around the world where it's not just about how long you live, it's how well you're living until then, right? So it's all about health span. Because even in Singapore, where we have, our average lifespan is pretty long, it's 82 for males and 86 for females. We're still looking at a health span that only goes up to their mid-70s, right? So many of them are going to live the last couple of years because of better healthcare, but not because they're actually fit, right? So they are sustaining, life, but may not be the best quality of life. So what we're trying to do is now narrow that gap such that as long as people live, we want them to live healthily. So I hope I answered that question.
Great perspective. One more question for you. So this is, Dr. Roscoe mentioned proactive. So you had mentioned that part of the cancer continuum is prevention. And I think there are unique things that we can, advocate for as prevention. But do you, in your role, also tie into prevention as a component of better health overall? I mean, there are factors that can be shared to improve overall health and not just cancer risk reduction. We think of, for example, obesity and the risk of cardiovascular disease as well as cancer, say alcohol use mitigation that has impact in multiple things. So looking in further upstream, this is not stuff that you want to start at 65. How do you say that if we want to maintain a healthier population, you got to start this much earlier in a person's life?
Yeah, a wonderful question. And in fact, if I just use the example of, this Healthier Singapore strategy, it starts from the point they're born, whenever a person is born, and you have to start inculcating all these lifestyle changes and habits such that they stay healthy. And that's not just going to help, cardiovascular risk, but we have seen so many epidemiological studies that link all of these together as well. You have diabetes, you have, cardiovascular risk. It's also linked to higher risk for cancer when it comes to habits, for example, smoking. And I think a few countries in the world have done this, a tobacco-free generation. If you're born after a certain year, you're not allowed to buy cigarettes at all, which means after a period of time, there'll be nobody smoking because, the generation that was allowed to buy will eventually pass on. So there are a number of initiatives that are taking place globally, and these things are going to make a huge difference to how, populations are going to, fight against this issue of chronic diseases. And cancer, slowly, many types of cancer is becoming a chronic disease. So it starts from the point you're born, and I think that's where countries have to start looking at making those key policy changes.
Yeah, thank you. Moving on to Dr. Pilleron, thank you again for your wonderful presentation here. You shared some very, perhaps sobering or very pointed information here, not sobering, but challenging information to all of us, that how the older patient population is not represented in clinical trials. I believe you showed a slide of lung cancer, right? That we recruit the younger, fitter patients, but the population in which the cancer is most prevalent is in the older population. So I would like to come back to you. You gave, some broad examples. Where are there examples? You showed a couple of, real world evidence trials. Are there some examples of where pharmacovigilance in the older population has led to, potential changes in thought and application, number one? Maybe that's a gap. And, how would you direct or recommend that academic and other institutions, more pointedly use real world evidence? If you had a choice of, you gave us a broad list, but if you say, this is what we should do right away, what are areas that you could suggest to us?
Thank you very much. Very tough questions. So I'm not aware of any studies using real world data assessing the effectiveness of treatment on anything in others specifically that change anything for now. Hopefully in the coming years it will be the case, but for now I'm not aware of that. Regarding what we should do, I guess we need to, because the most challenging things today is the lack of evidence on treatment effectiveness in older population. Even if real world data are not perfect, at least they can be used to fill that gap for now and to provide some evidence. And mostly if we can show in different data sets in different countries, ideally, that one treatment strategy over another one is more effective in older patients, we can have enough evidence to show that there is something here. That may have two main consequences. That the first one, that maybe that can change practice, that could be included in clinical guidelines and provide some guidance for clinicians, but also another thing, it could also motivate some pharmaceutical company to explore that strategy further and to run a randomized clinical trial. So there are, so I guess that the most pressing thing today is providing evidence on the effectiveness of treatment strategy, because we know that in practice, because there are clinicians are treating frailer patients, they have to adapt the treatment. So it may be reducing the chemotherapy doses or things like that, but we don't have ever any proof that it's effective enough and what is the outcome for this patient in terms of quality of life, in terms of toxicity, complication, and survival. So I think it's the first thing that I will do. But with real world data, if it was possible, because it's very difficult, the main difficulty in doing that is that we need data on geriatric factors. And in many data sets available, we don't even have comorbidities. So it's difficult to really understand which patient will get the treatment for good clinical reason, and those who are probably not good clinical reason, but this kind of thing we cannot know, because as I said in the presentation, if a patient refuses treatment, it's right, but this information, for instance, is not recorded in any electronic medical record. So we cannot take that information into account. That is a bit extreme, but it's a thing that we are facing. But with real world data, we can do many things as well. We can characterize a patient who is getting treatment, who is not getting treatment. We can also basically describe the treatment pattern and see if there are any changes over time. We can, as I've already mentioned, assess effectiveness of treatment, but we can also use this data to do some prediction, to predict early death, for instance, or toxicity in older patients with cancer. But they can also be very useful in cost effectiveness studies that we are needed now to prove that some strategy could be cost effective. And there are more and more interest in the prevention side, even for adults. And with real world data, we can even, in some countries, you can have data linked basically from birth to death. So we can have the entire life, at least medically speaking. And so you can do studies looking at before the diagnosis, what are their lifestyle, what are the diseases they get, and so on, and how they could impact also the cancer risk. So yeah, real world data could be very useful. And real world data is also data coming from your smartwatch or your smartphone. And so it's more and more used, or at least there are more and more interventions looking at the utility of these tools in managing treatment, toxicity, for instance, and the quality of life with all these PREMs and PROMs we can assess using an app or something like that. So this is a fantastic resources, but as I mentioned, there are a lot of challenges when using this kind of data. And even if there are a lot of data available out there, mainly from the US, we have very few data from low and middle income countries, for instance. So we really need to have more resource, meaning funding, to help these countries as well to digitalize even the medical record and to have data from there. Yes, I think
Thank you.
Did I answer your question?
No. Yeah, I realize the challenge, but I'm going to throw another challenge at you. Chuck mentioned that one of the most important considerations when he was thinking of treatment options, and speak up, Chuck, if I'm misrepresenting you, was the quality of life that is good to maintain. And one of the things you mentioned in real-world evidence assessment, beyond toxicities, we recognize that quality of life is above and beyond sort of, clinician report toxicities. How are you seeing patient-reported outcomes, and have you looked at that as a component of real-world evidence?
So not individually, it's something that I plan to do in the future personally, but yes, there is a limitation. Usually this kind of question are answered by questionnaire, and not every patient answers this type of questionnaire. So meaning that probably for instance, in the UK, it's mandatory to have this survey is on some period in the year. They are asking this survey in patients with cancer hospitalized for a day. But we know that other patients didn't answer this type of questionnaire because they don't see the point, or they don't have time, or for more reason. And people with advanced disease as well are not answering this kind of question. So we will get this information, but not for all patients, and probably not for the frailer one and the oldest one. So that's the issue with real world data. They are not specifically to study, to do research and to use them as an outcome for studying the effectiveness of treatment or an intervention, something like that. So it's possible, not everywhere, unfortunately. And I think it's a way to go. But again, if the data is not recorded, we cannot analyze them, or we can do some cross-sectional study to include, to ask this specific question at some point in the year, for instance, or something, to do specific studies. But at population level, I think we don't have that kind of information, unfortunately. But yes, I agree that quality of life is probably the most important.
Thank you, but we do recognize, there's so much more to learn from real-world data to augment, information from clinical trials, which usually have a much more narrow endpoint or time focus. So let me move to Ms. Lavery here. You've heard all this, so now we pose all these challenges to you. You work in the industry, you work with regulatory bodies. What are some of the ongoing efforts that you know of at FDA and EMA and other regulatory bodies to address gaps in the information for older adults with cancer? And then to turn it more specifically to industry, what are efforts, I'm not trying to dig into your company secrets, but what are your efforts that you are taking or championing to increase participation, collection of information from this population that represents an increasingly large number of incident cancer patients, but yet are underrepresented in clinical trials?
Thanks, Dr. Ko. I will start with the regulator question. There's actually a wealth of information and activity by the regulators since the 90s, actually, with the International Council of Harmonization and their E7 guideline focused on geriatric populations. At the time, that's what it was called. We've also seen escalation of guidance documents from United States, specifically to older patients, as well as the mandatory collection and description of demographics of patients in our clinical trials, so that it's very obvious and transparent who was studied. And that information now goes into product labeling. We've also seen this with legislation passed in 2022, where diversity action plans are now a mandatory requirement. And just yesterday, the draft guidance was released by FDA regarding the content and the context of those diversity action plans as part of the legislation. So a lot of activity in the US. EMA has also been very active in Europe. There's also a recent reflection paper in 2020, and all of the themes are very consistent. Even though it may not be limited to older patients, there are common themes that go across any grouping or subgroup of patients that are typically not included in clinical trials. And then there's additional considerations for those that are older. To answer a trivia question earlier, oftentimes sponsors are mandated to report age subgroups for 65 to 74 and 75 and older, which is why often you see a lot of data reported with those age groups. And so that's from a regulatory requirement. When we look to now the challenges that actually I share a lot of the perspectives that have been shared here, and actually it's no secret, a lot of the work that we're doing on sponsors cannot be done by a single sponsor or alone. It actually has to be done in partnership with all sponsors as well as cross stakeholders. What we're finding is there's probably 3 major areas of tactics in which we are looking at this. The first is the strategic. When we look at why patients are typically not included, it starts at the very beginning with the stringency of inclusion and exclusion criteria. When we first enter into humans for clinical trials, the first concern is the safety and tolerability and the dose optimization for patients. With that, you often see exclusion of more common comorbidities and performance status factors that then represent majority of patients in the community. Now, ideally, you would expect that as you then get more information on safety and tolerability, as well as activity, you could start to learn about where you can relax that inclusion and exclusion criteria. And this is the fear that you might often see from sponsors, which is a concern that if you relax it too much, you will have a dramatic increase in your safety profile and adverse events, which could then change your benefit risk of the product. So that is a fear that's well known, and we've actually talked about it in many open forum, and it's one of the things that we're actually looking at to say, how could we do it in a more targeted manner? And so that's why the concepts that Dr. Pillaron talked about with real-world evidence, how could you use that information to help guide your decisions on how you design clinical trials? For instance, maybe you don't try to do everything at one time. You look at in the real world, what are the most common comorbidities in a specific cancer type that might be the first one to tackle? What might be that one? It could be actually related to blood pressure or diabetes. It might have something that has a high prevalence in older patients. That's a more pragmatic approach. We are also looking at how to do parallel investigations. So maybe it's not in your primary randomized pivotal, but you do a parallel smaller sub-study to then look at the right safety, dose optimization, et cetera. And then, so that's the strategic. Operationally, we have been doing a huge amount of work in partnership with healthcare ecosystems, hospitals, academicians, treating physicians, patient groups. And what we often hear are there are a lot of challenges that have increased burden on patients. So not only their will to participate in a clinical trial, but to also remain on the clinical trial and actually complete the experience. So what Chuck had actually mentioned, in addition to potential financial toxicity, we found that there's a great need for additional education literacy to understand the value of clinical research in the entire healthcare ecosystem and in the care journey. We've also seen that sometimes it can be quite scary to navigate a clinical trial with the additional assessments. So really bringing in patient groups to help us design not only the design itself, but the conduct, the number of assessments. Where might be the best place to do a local lab for your blood draw instead of having to go to an institution that may be far away every single time? But we also heard from patients that they want to see their oncologist. So don't make it completely decentralized. So it's a learning process for all of sponsors as we work to operationalize these and address these challenges. And then lastly, multi-stakeholder consortia groups. This is the only way that we actually move through these challenges, because as I mentioned, you can't do it alone. And especially one company, one individual, we don't have all the expertise. So being able to look at lots of different perspectives, potentially not also, look broadly about different perspectives within a segment. For instance, not only talking to a single patient or caregiver advocacy group, talking to many, because Chuck, I would imagine you would say, I'm in a sample size of one, there could be many people that look like me on paper, but that are not me. And so I think having those different perspectives are really important. So I'll pause there.
And it's great that you're including the patient voice, the patient perspective, and you need, many Chucks on all your clinical and drug development program. I do have a question, Dr. Pilleron, very briefly, when the clinical trials process, phase 1, phase 2, you talked about the fear of safety issues. There has been some talk that the historical paradigm when we evaluated cytotoxicity, we always went to the maximum tolerated dose. And perhaps for the biologics and the targeted agents, we don't need to push that, maximum tolerated dose paradigm. Is that something that you all are thinking about in terms of how to design clinical trials without having to push to that maximum tolerated dose?
Absolutely, Dr. Ko. This is actually part of a very public effort also by FDA Oncology. They call it Project Optimus, but this is a conversation that's been happening in the design and development of clinical trials for many years, where if there isn't a rational reason why you are pushing for a higher dose and you maybe potentially haven't looked at enough doses, we are actually being pressured to, and as we look, actually, there is some truth to looking at what is the PK modeling telling you? What is the mechanism of action? What is the likely window? Are there reasons why we are designing our dose strategies the way we are? So I think what we're actually starting to see is what often happens in a lot of other diseases, where you see a lot of dose optimization in chronic diseases, for instance, neuroscience. So we do see that quite a bit. And this is where, once again, it's a partnership. And also real world evidence, how we might expect, especially when we're combining with standard of care or chemotherapy, to really understand what might be the right doses to be testing and when. And when we select one, we actually have to provide quite a lot of rationale to the agencies as to why that's the right one to take forward.
Yeah, great to hear. Thank you for your perspective. I'm going to turn to Chuck and Dr. Roscoe. Looking at clinical trials from the patient and provider side, and Dr. Kanesvaran, you're also a practitioner. You can please chime in. What are things that you can suggest that can be done now to help patients, especially older patients, navigate clinical trials? We've talked about some of the issues, but what are the things, in terms of your proactive program, what do you see that patients need that you think should be much more broadly instituted in the entire clinical trials program? Let me start with Chuck.
Well, first of all, the minute you say clinical trial to me, it means I'm in trouble. It means standard of care isn't working and I'm scared to death. So when you suggest that, just a quick story. When I was first diagnosed with cancer, from the day I was told I had cancer till I saw my doctor was probably less than 2 weeks. And that much time, I'd gone to the internet and found out all the reasons I was going to die. That it was huge. I ran into all sorts of things. I didn't know how to search what was important. I was brand new to this. So what I'm getting at is, I think as a physician, and I see you, and you mention a clinical trial, you need to educate me really well. Be very honest, explain why it would be good for me to go on a clinical trial, what the upside is, and what the downside is, and just be very honest and point me in the right direction. If I do want to do some research myself, let me know where I can go to get good information, not just hearsay and things that are just going to be scary.
That's a great perspective. Dr. Roscoe?
Yeah, I think Chuck brings up such an important point about just, kind of overall bias and history of clinical trials. And I think that there is, there are challenges just even to begin with about starting about why clinical trials are important and being able to kind of shift that messaging about clinical trials, Chuck, because I think your perspective is shared by a lot of people's perspective about, the benefits of clinical trials and where patients are coming from. And even in my own practice, it's a great starting point for a conversation. And, I often start by, talking to patients about, all the drugs that we have available today for this therapy are because patients before you had, participated in a clinical trial. But it does take time in order for us to be able to start those discussions and not only oftentimes even, starting about the diagnosis itself, and then to take a deeper dive into clinical trials and why we're offering them. I want to point out a couple of points that Bea had mentioned in her presentation about clinical trials as a whole and being able to offer clinical trials to more older adults. I think one of the critical points about with working with sponsors about even the devising of clinical trials for older adults specifically. I know we had talked about how safety and tolerability are first and foremost, but also the real problem is the fact that those very strict restrictions that are devised in phase 1 clinical trials get carried through into phase 3. And then in doing so, the patient population doesn't fit, and as Dr. Pelleron had presented, doesn't fit the patients who actually have the malignancy. It doesn't fit that age demographic. And a lot of those, there are restrictions that, patients wouldn't ever be eligible for those trials. There are flat out very easy ones, like there are still age restrictions in clinical trials, and it doesn't make sense. There's no biologic reason why a patient who is 80 years old versus 79 years old could not be enrolled into a clinical trial. But there are certainly age restrictions that are still built in clinical trials in this day. We talked about it historically, but all of those things are still there and they're still present within sponsorship to be able to, there are just age restrictions. And two, that there are other much more subtle and occult ways that older adults don't get enrolled into clinical trials. And the FDA has put out guidance statements on this specifically, things that are related to, using GFR instead of creatinine clearance, things that are limited to secondary malignancies. We know that even in our patient population, the patients that we see in our cancer and aging clinic, a third of patients have had two malignancies in their lifetime. And many of those are not in active treatment, but there are sometimes language restrictions that, that have limit, a patient that has had history of breast cancer, prostate cancer, or even more recent cancers that exclude them for participation in clinical trials. So those are things in which, there can be, with early involvement of those that are involved in the older adult oncology community, and many of which, to say, where are these kind of occult vulnerabilities, to be able to design within with sponsored design of clinical trials, I think would be very informative. And then there are other, financial barriers in terms of access and being able to get, there's often an increase in frequency in appointments for clinical trials. And as Chuck has previously mentioned, that's a burden, that is a patient burden, and that is a caregiver burden in order to be able to participate in clinical trials and have more frequent visits. And then lastly, I think that there does need to be some integration with legislation in terms of that carrot and stick, and saying, okay, we want to be able to get trials that are, safe and effective, for patients with this malignancy. But in the real world, these drugs are going to be delivered to patients that, have many more comorbidities, many more medications than the patients that are enrolled into those trials. And then how can we get subpopulations studied, and how can we get special populations enrolled to be able to ensure that the patients that are more reflective of what we're seeing in the community and more reflective of what we're doing, to make sure that they're safe and, for that patient population, because that's really who we are using those drugs most for. And so I think having, and that really, and those are, 10-year investments, those are 5-year investments, to say, how do we kind of engage from the design of the studies? By the time that it gets to the institution, we have reviewed clinical trials and say, it's really hard for institutions to change eligibility criteria. There's not a lot of wiggle room there. When we're doing investigator-sponsored trials, that's a different thing. It's different than working with our pharmacy partner, pharma partners, to be able to design studies when the investigators are writing the studies or through the NCI. Those are and sometimes you think that those would be more open, but they're also quite rigid. And so institutions, when they're writing their own studies and things like that, also need to be aware of a lot of these types of clinical trial eligibility. So to point about saying, there's bias that comes from the patient and from the physician, and saying well, I don't want to, I think this would be good, but, I know that they have a sick loved one at home, or I know that they, there's bias that comes from both ways in terms of clinical trial. And then just there's time and resources, and, and those types of things have to be able to be accounted for. So it's a multi-level tiered approach that needs to have interventions. There's not and there are studies here in the US being able to kind of integrate that, but there's not a single fix. We have to work on it from multiple angles in order to be able to better navigate clinical trial enrollment for older adults as a whole.
Thank you. Dr. Kanesvaran, do you have any thoughts to add?
Yeah, so I think most things have been mentioned, and maybe what I can add to that is more of a perspective from, an Asian, oncology patient or an older adult in Asia with cancer and their perception of clinical trials. So having spent a bit of time as a uro-oncology fellow in, a leading comprehensive cancer center in the US, what I realized in the clinic was, patients travel, far and wide to come to that center for trials because it represented hope, right? And in fact, in the mind of these patients, it was their best chance of, getting as good a survival as possible. In Asia, however, trials, partly a bit like what Chuck had mentioned, were perceived as them being part of, them being guinea pigs in a study, right? So trials are really very far out from anything, Asians would accept. I think one big difference would be maybe education, because they're not made aware about the value of trials, especially in a disease that's terminal, and how it actually can potentially improve their care. But more often than not, I think in general, because cancer is relatively a taboo subject, so people don't talk about it. And when you don't talk about it, you don't get enough information. You don't even want to broach the topic. In fact, when I broach the topic of a trial, it's a big, challenge to then dig myself out of that hole to try to, explain things. I think one big difference is there's been, I guess, more emphasis on patient advocacy, and more of these groups are being formed right across Asia. And I think by connecting with each other, we've come up with strategies on how to overcome this within our patient population. So now we have, patient advocates who come and volunteer as navigators for these patients. When they first get diagnosed, they share with them their experiences, and in that process, explain what trials are about, how it's a critical part of their whole treatment paradigm. And I think slowly that thinking is changing. But yeah, it's a huge challenge in Asia to convince patients to get on trials.
Oh, thank you. You all touch on a very important subject. NCCN has been on record supporting the importance of clinical trials, but recognizing, the various factors that come into play. We have actually recently changed our clinical trial statement. Some of you may know that historically, we actually had the statement for the past 15 years that NCCN believes that the best management for any patient with cancer is in a clinical trial. We felt that that was kind of outdated and perhaps a little bit, as Chang mentioned, concerning. We've now changed the statement, and this is now going to be focused on the front page of every guideline going forward. NCCN recognizes the importance of clinical trials and encourages participation where, when applicable and available, trials should be designed to maximize inclusiveness and broad representative enrollment. So a much broader thing, and you're bringing in the importance of the patient voice and education. Let me turn to a question that was posed from the audience. Many of the questions have already been answered directly by you all as panelists. But one question that's posed by a pathologist. As a pathologist, a particular challenge faced is the diagnostic process, in that they are asked to make, a diagnostic statement in the relative absence of clinical history like comorbidities or other, as we're talking about in an older patient population. How should that information be made more available? Should that be reflected in the pathology report that can also guide, clinician decision making, that rather than just, grade, histology and things, can there be a more comprehensive, not just pathology, but diagnostic report? And are there examples of best practices, practical solutions, digital solutions that would allow diagnosticians to put this into their reports? So anybody want to take a stab at this?
I could say something. I guess moving towards multidisciplinary meetings, or in some places would be tumor boards, and moving to kind of a concept where all cases are discussed in such platforms may help the pathologist better understand these patients. What are the other clinical factors that come into the picture when we decide on the bigger picture in terms of what kind of treatments we're going to offer them, and how the diagnosis plays a big role in that. I think it's always a challenge to put all the history in when we send these patients for biopsies, and subsequently when the tissue is sent to the pathologist for reporting. And very often we miss out information that can actually help them with the diagnosis, and subsequently there'll be a lot of interaction. But having most, if not all, these cases discussed as part of a multidisciplinary kind of setup would make a huge difference. I think this is a challenge more so in low middle income countries where it's hard to get all these doctors, because time is a constraint, resources are constrained, you have a lot of patients to deal with. You may not get this opportunity. It's pretty much standard of care in developed countries, but in low middle income countries, it's an issue. I think technology has helped us make this leap. So I think, just to answer that question again, if that expertise is not available in let's say geriatric oncology, now what we have done is we have started opening up our services to low middle income countries for them to join our tumor boards, present their cases in our tumor boards as well, and see how we can help them out. And because now it's so easy to do it, thanks to the pandemic. One of the things that has really and that's this platform as well, Zoom, right? It's made us more connected that way, without actually increasing cost. Of course, there's a time cost to it. But I think it's something that we can easily overcome. And if you really want to help people, we can bridge that gap through technology.
All right, thank you. Oh,
I
sorry.
have a
Go ahead.
comment.
Yeah, go ahead.
I'm just curious, or I guess it's more of a statement. Without doing a geriatric assessment, how do you even know what direction to start treating these people? I agree that you may not know much, but if you don't ask the questions and do the testing, how do you decide on the treatment that's right for me? I'm 77, and I would really want somebody to look at all the different domains and make sure you were giving me the right doses, the right treatment.
You raised a very important question, and let me add to that. And I realize we're running close to end of time, but there were a couple of questions that related to in the quick Q&A to AI. Now, I don't want to open Pandora's box because that could spend another day. But looking to this, are there technological situations when one tries to figure out, as Dr. Roscoe said, biological age, doing geriatric assessment, as Chuck said, looking at, querying the real world data. Are there some thoughts about where AI may help, inform appropriate care? Dr. Ashley, do you want to take, Dr. Roscoe, you want to take a stab at that? And then Dr. Pillaran?
Yeah, I mean, I think we're looking into ways to be able to kind of mine the electronic medical record in order to be able to identify prognostic factors. But I think the problem is that a lot of the kind of standardized geriatric assessment measures that we recommend through the NCCN older adult oncology guidelines are not systematically instituted. And so I think, being able to integrate disease-specific measures with treatment measures, with geriatric-specific metrics, we have a missing data lake, right? And so we have a lot of the things there were some questions about, cognitive impairment screening and physical vulnerability screening. Well, as much as we recommend, we know that there is a barrier in the ability to deliver and administer these assessments. So one of the, just kind of challenges we see when we want to be able to even pool institutional data and be able to kind of get have the AI integration of data pools, is that we have this, we have some standardized metrics in different domains that we're looking for, and we can kind of define our levels, thresholds of impairment, but we still are kind of need to get that systematic administration. Ways to do that, are saying, well, we have this whole group of patients that are getting clinical trials, and then we can systematically deliver aspects of the geriatric assessment into clinical trial assessments. Those are ways that we can do that, where we can say, here are the aspects that we need, kind of the core domains, build those into clinical trials in terms of just like how we do performance status and how we do cardiac performance and how we do all these other things that, we don't kind of think twice about. But then we ask about a geriatric assessment, and then it says, well, it's time, it's resource intensive. I'm like, relative to a lot of many other things that we do with biopsying and imaging, it's really kind of quite minimal.
Dr. Pillaran, any thoughts on this? On the role of AI in advancing knowledge?
Yeah, I think before using sophisticated methods such as AI, we need to work on improving the quality of the data in general. And also, if we don't have any geriatric variables in our data set, we won't improve anything for our older patients. So I think we really need to advocate for increasing the inclusion of geriatric variables in all oncological studies, regardless of their design, randomized clinical trials for sure, but also in observational studies, in any studies involving patients older than 65 should have this kind of variables. And another thing is that, as Dr. Roscoe mentioned, that we need to have a lot of data, and so we need to have to use different data sets across institutions. So we need to have data standardized across all these data sets and institutions. And there are some initiatives in Europe doing that. So maybe in the next decade, we can have that. But for today, it's a bit too early, I guess, to use AI to improve the health of other patients.
But I think, thank you again. And I think Chuck has raised, the clarion call that, we need to make these geriatric assessment tools much more a part of the standard of care and raise awareness. And this is one of the goals of the summit. So I wish we had a lot more time. I've learned a lot, but I'm going to give each of you 30 seconds, in your professional advocate roles. What is the one thing, 30 seconds, that you say, if I had, all the wherewithal, the support, that I would like to advocate for a strategy or policy change or implementation? So I'm going to go a little bit in reverse order of introduction. Let's start with Ms. Lowry.
Thanks, Dr. Ko. I think the biggest thing that we see is that there are a lot of assumptions embedded in how we do both clinical research and how we deliver care for older patients. I would ask everyone to take accountability for that and uniquely solve the area that you are accountable for. And in our area and sponsors, it's really changing the assumptions we make through the entire clinical development plan, which includes how we include patient voices, how we design our studies, how we then deliver the data that will be important for those patients. And to do it, not necessarily because we're legislated to do it because we actually genuinely want to integrate older patients into the entire continuum.
Thank you so much. Dr. Pillaron.
Okay, as a researcher, I think my team and I will continue to work on improving cancer outcomes by better understanding drivers of age-related disparities across the whole cancer pathway. So yes, from diagnosis to survivorship. So I think it's my strategy to try to improve the outcomes for other adults with cancer.
Thank you so much for your work. Dr. Kanesvaran.
Yeah, so as a clinician, I think the main message I have out there is recognition by everyone in this space, whether you're a surgical radiation oncologist, allied care specialist, nurse, we are all geriatric oncologists, right? All of us deal with older adults with cancers. So once that recognition kicks in, then I think the onus is upon us to update, upskill ourselves, get to know what this whole space is about, why we need to treat older adults as a unique group that needs special attention and care, just like we do our children with cancer, pediatrics. So I think that's the only thing. It's not a specialty by itself. All of us are in this space. We all need this knowledge. Thank you.
Great, thank you. Dr. Roscoe.
Yeah, I think one of the major needs in this space is really resources and funding to be able to support older adult oncology, therapeutic trials and non-therapeutic trials in this space. And so I think one of the main barriers that we see from a training and education, from the integration of basic science to health outcomes research, to therapeutic study design is that, the focus on aging science and being able to integrate that into cancer care is really an unmet need.
Thank you. And Chuck, you've already, raised the call, and I want you to hold us all accountable to oncology, but your last words here.
My last words would be, as a patient, advocate for yourself. Stand up and make sure your questions are answered, and don't be hesitant. Don't be intimidated. This is your life you're talking about, and make sure you have all the answers that you need.
Well, thank you so much to the panelists, to our keynote speakers, Dr. Kanesvaran, Dr. Pillaron, Ms. Lowry, Dr. Roscoe, and to Chuck O'Shea. Thank you for all of you joining us in the audience. And we look forward to actionable steps forward in dealing with this very unique and special population.
Thanks so much, Dr. Ko. I want to just reiterate our thanks to everyone who joined today's webinar. I want to thank Dr. Ko, our excellent moderator, as well as all of our exceptional speakers for sharing their expertise and insights. I think overall, we're experiencing aging populations all over the world. You can see a lot of work, and a lot of passionate advocates have been doing a lot of work in this area for many years. but a lot more work needs to be done. And I would like to thank Matt Izzo. From start to finish, he planned this entire webinar. He did a seamless job and he put in a lot of effort. So a huge thank you to him, as well as our amazing meetings team, Mike Abrams, Liz Reeder, and Mark Geisler, who do all the work behind the scenes to make this webinar a success. Again, thank you so much to the supporters. Without your support, today would just not have been possible. I think one of the attendees asked about recordings. Yes, we will post a recording of this webinar shortly on our website. Please feel free to go to this link, and it should be posted within the next couple of weeks. I'd also like to invite everyone to join us for our next session. It will be on October 24th, focused on the growing role and the current state of patient advocates in cancer research and clinical trial design and development. I think it actually builds really nicely on a lot of the areas that were talked about today. Registration should be open very shortly. Thank you again, stay safe, and have a great day. Bye.